This meeting is being recorded.
Got it. Hi, everybody. Evening. I'm VG Naidu. Welcome to all. ECHO is hosted by the Gastro Foundation in association with the Project ECHO from the University of Mexico. ECHO Fellows is run every Monday at 6 o'clock, and feel free to place your questions in the in chat. So that'll be open for questions or comments. So our presenter this evening is Barbara Makumbi, and she'll be speaking to us on lower GI sort of bleeding. So I'm going to hand over to you, Barbara. I think you're going to share your slides soon. Thanks.
Barbara, please unmute.
Good evening, everybody. My name is Dr. Barbara Makumbi. I am a fellow at the University of Wits. Today, I'll be presenting the topic lower GI bleed. So I'm going to begin by talking about the definition of a lower GI bleed. In theory, the etiology of lower GI bleed is defined as bleeding beyond the ligament of triads. However, in most guidelines and in the scope of this talk, we'll be talking about bleeds beyond the ileocecal valve, so that involving the colon and the rectum. The natural history of lower GI bleeds generally is a favorable outcome. Most of these bleeds, 80% of them actually stop spontaneously. However, there is also a concern about rebleed. Just to highlight further definitions, I'd like to just highlight the definition of overt, covert, occult, and obscure bleeds. Overt bleeds are those that have a visible source when you basically investigate the patient with bidirectional endoscopy or other means. Overt, covert, or occult bleeds are blood loss that's not visibly obvious, but evidence towards its existence does exist. And obscure bleeds are where the source is completely unknown. You have a patient with iron deficiency and you need to actually investigate and see why this patient is bleeding. To differentiate between upper and lower GI bleeds further, clinically, you'd have melena with your upper GI bleed. With a very brisk and severe massive upper GI bleed, you can actually have bright red hematochezia. And to help differentiate, it's useful to look at your UNE and look at your urea and creatinine ratio. So a urea creatinine ratio of more than 30 is indicative of an upper GI bleed. And basically when a patient's very unstable, you can also consider this and do a gastroscopy as part of your workup. Some of the guidelines do mention nasogastric lavage and aspiration. G-scope is more of an effective means of investigating these patients. With lower GI bleed, a patient may have melena if it's a right-sided bleed, so they can still have melena. They may have clots. And a left-sided bleed may have bright red blood and maroon stools. In terms of the epidemiology with lower GI bleeds, in terms of all gastrointestinal bleeds, 20% are acute lower GI bleeds. According to the UK stats, 33 to 87 out of 100,000 population get lower GI bleeds in a lifetime. And those that are in hospital, their mortality is 3.4% for these patients. 20% of these patients need red blood cell transfusions of more than 4 units. And mortality is basically based on patients' comorbidities and the elderly who will have more comorbidities inherently. So looking at causes, the most common causes of lower GI bleed, which I'll elaborate on later in my presentation, are diverticulitis, your anorectal pathologies like hemorrhoids, which can actually not always be massive bleeding, but can actually present with quite torrential bleeding. You can have ischemic colitis, colorectal polyps and neoplasms, post-polypectomy bleeding, Angioectasias, and the list that we can see on this slide. This on the left-hand side, it was divided quite nicely into categories of anatomical, vascular, neoplasm, and inflammatory causes, and inflammatory being divided into infectious colitis, as well as your non-infectious and your IBD causes, which I thought was a very nice approach. Busy slide, but this is basically an outline of your management, which can be found in the ACG guidelines, which are online. This is basically the question to everything that we are going to talk about in the talk, but I'm going to elaborate on each detail. So your initial assessment when you first see a patient with a lower GI bleed, going to look at the patient, look at the severity, localize where the bleed is, try and localize the bleed clinically, and try and think of an etiology based on your history and examination. But while doing this, you resuscitate the patient simultaneously. This all happens in tandem. It's important to establish whether the patient is stable or unstable. An unstable patient, you can use a shock index score. So the shock index score, I think that was BSG guidelines or the AGA guidelines that highlighted the importance of this, where you look at your heart rate of the patient divided by your systolic blood pressure. If this value is more than 1, then the patient is unstable. So your shock index score must be used knowing what drugs your patient's on. If a patient is on a beta blocker, obviously your patients that have portal hypertension that are on beta blockade, this is very inaccurate. So you need to keep that in mind. As well as other scores, many scores exist. There's another score called the bleed score, and a few that are listed in the guidelines. When we have a shock index that's actually less than 1, the patient's stable. And when a patient's diagnosed as stable, they have major or minor. They fall into those 2 categories, which I'll elaborate on too. So basically, if you have a low risk and a high risk patient, this will help you triage your patient, get your timing of colonoscopy or any other intervention that you'd like, and determine what level of care your patient has. So I said that a stable patient falls into the major bleed or minor bleed. And to determine this, there's the Oakland score. And the Oakland score is actually validated for lower GI bleed specifically. It's one of the few scores validated specifically for lower GI bleeds. And it uses variables related to the patient's age, gender, whether they've had previous admissions for lower GI bleeds, their digital rectal examination, vitals, and their hemoglobin. So the cutoff for the score is 8, depending on the variables that are found. And if the score is less than 8, your patient can go home safely. It's a 95% chance that the patient will have no rebleeding or low risk of rebleeding, not need a transfusion, and not need any intervention thereafter. If your patient has a score more than 8, then there's a major chance that the patient, well, it says a major bleed, and the patient does need intervention, probably a transfusion. It does not predict mortality. And with all these scores that do exist, it's very important to highlight that you need to use your clinical acumen, sorry. You need to use the scores to help, but you must look at your patient clinically. So going back to your stable patient that's a minor bleed, they can go home, but they need to come back for investigation. So your minor bleed can be discharged. They can have a colonoscopy within 2 weeks as an outpatient. And you counsel your patient, make sure that they know that if they have a rebleed or they feel like they're getting ill, they must come back to hospital. So in a patient that hasn't had a recent colonoscopy, it's also important because you could actually have a patient that's bleeding from a malignancy, especially the guidelines say over 45, we need to screen. If a patient has a major bleed, admit the patient. History examination, I'm going to gloss over this for the sake of time, but you need to discuss, find out what the nature and duration of the bleeding and associated symptoms that the patient has. The history can allude to your etiology. Find out what the specific GIT symptoms the patient has are, the timing of the bleed, how quickly the bleed progressed, and who actually witnessed the bleed. In past medical history, you need to determine safety in terms of cardiovascular pulmonary diseases, to investigate your patient further, and also like allude to your etiologies in terms of, does the patient have previous peptic ulcer disease, or does the patient have diverticular disease, portal hypertension, etc. Did the patient have previous abdominal pelvic radiation previously? Have they had abdominal surgery previously? And if they're on antiplatelets, anticoagulants, DOACs, very important. You take a full history, substance use, is the patient a smoker? Do they use drugs, illicit drugs, or any alcohol? Do they have a family history of inflammatory bowel disease, or any family history of colorectal cancer, for example? And clinically, you'd assess them. You do your digital rectal examination, determine the color of your stool, any anorectal sources, masses, look at the perianal area. And labs, you do your full blood count, your UNE, INR, and type and cross match. In terms of resuscitation, you do your ABCs for the patient. It's advisable to give IV fluids, crystalloids particularly. And looking at transfusion, both AGA and the BSG promotes restrictive transfusion methods. So if a patient doesn't have any cardiovascular pulmonary risk factors, and the patient doesn't have a massive bleed, the trigger for transfusing them is a hemoglobin of 7 and aiming for a target of 9. If the patient has those risk factors that I've mentioned, the trigger for transfusing is an HB of 8 with a target of 10. Many studies have been done in critical care with regard to these values that have been formulated, and it relates to an increased 6-week survival, as well as reduced rebleeding times, especially in your portal hypertension patients. And then they said with the restrictive with patients that do have cardiovascular risk factors, being too restrictive with those patients increases the risk of myocardial infarct and cardiac arrest. Looking at coagulation defects, a patient has ongoing bleeding, but they also have thromboembolic risk factors. It's a difficult risk versus benefit means to juggle. In terms of drugs, I'll highlight the details with respect to drugs later in my presentation. But looking at endoscopic hemostasis, an INR of 1.5 to 2.5 should be fine to take a patient to like endoscopy, colonoscopy, and do your interventions, and do radiation, angiography as well. If the INR is more than 2.5, it's advised that you use reversal agents. This is implying warfarin, but I'll allude to that later. And platelets, they say if the platelets are less than 50, we want to maintain them more than 50 in a patient that has a massive bleed who you're going to take to for intervention. They spoke about massive red blood cell transfusion and a ratio of 1:1:1 with your yellow, your platelets, and your FFPs. Colonoscopy itself, just to say that with your patient stabilized, this is your initial diagnostic procedure, your first line, in order to do your diagnosis, get your diagnosis, as well as intervene on the patient. It is important to have a terminal ileum intubation with these patients in case the bleed is actually proximal. And you're looking for your high-risk endoscopic stigmata. So either the patient has active bleeding or not bleeding currently. Active bleeding, you're spurting and oozing. Non-bleeding signs would be your visible vessel or an adherent clot. The prep differs for your acute lower GI bleed. So it's a large volume prep and rapid protocol. You try and stabilize your patient, and then you give 4 to 6 liters of the PEG-based solution. And they say you can give some water enemas or glycerine enemas. This is administered over a period of 3 to 4 hours. And then this is done until they basically say until you have clear fluid coming out PR with no stool or blood. In some patients who are less stable than others, and nasogastric tube may facilitate this. So they do advise that regardless. And I did allude to that when we were talking about the upper GI bleeds and aspirating and having a look at what comes out of the stomach. And in terms of the colonoscopy, they say when the PR fluid is clear, however, 1 to 2 hours after the completion of your solution is ideal. The risk factors with PrEP with these patients, aspiration with everyone, electrolyte and fluid disturbances, hypotension, nausea and vomiting. It's advised to give a prokinetic or antiemetic agent, your metoclopramide, to assist gastric emptying and also decrease the chances of vomiting and nausea. So the timing of colonoscopy is quite debatable and quite controversial. A lot of papers differ from each other, but the guidelines stipulate that a patient should, if they're high risk, have an urgent colonoscopy, which means less than 24 hours from presentation or when they were stable. So if the patient's not high risk, no comorbidities, you're not worried that this patient's going to decompensate, the next available scope list is fine. So one of the, I think BSG said 12 to 24 hours stipulates an urgent colonoscopy. It improves your diagnostic yield. It reduces hospital length of stay, but it's debatable whether there's improved rebleeding, and it's debatable whether there is decreased need for surgery. So there was a paper that I looked at that looked at the efficiency and safety of early versus elective colonoscopy for acute lower GI bleeds. And this paper said there's no increase in your amount of hemorrhagic stigmata found when you actually do your endoscopic, when you do your colonoscopy. And they said that there's no reduction in the amount of rebleeding, which actually was stipulated in the guidelines. There are a few papers on this, and they all say different things. Endoscopic hemostasis. So there are a number of options depending on the cause, depending on a lot of factors that you can use to have hemostasis in a patient. One being injection with epinephrine, contact thermal intervention with bipolar or multipolar electrocoagulation, your APC through the scope clipping devices, band ligation. They talk about hemostatic topical sprays and powders, which needs, and large over the scope clipping devices. Most of these need to be used with 2 interventions together. Just to highlight that epinephrine, you inject submucosally, 1 ml at 1 is to 10,000 around the target lesion, and avoid in your portal hypertension patients injecting into hemorrhoidal, well, obviously your varices, and other patients with hemorrhoidal vessels, don't inject into those. You may drain into the systemic circulation. I think that's obvious. And then I just highlighted the settings that are used in the colon. It's important to note that you have lower settings used in the upper and lower GI. CT angio. So to elaborate on CT angiogram, in an unstable patient or that comes in unstable and is not responding to your resuscitation technique or resuscitation at all, you need to localize the bleed. So we localize the bleed and do a diagnostic CT angiogram. This is then followed by angiography with your catheter angiography if a lesion is found. So it's widely available, CT is widely available, it's feasible. The sensitivity for CTA is 79 to 95% with a specificity of 95 to 100%. The velocity of bleeding, so you need bleeding to be active to detect the bleed. So 0.3 to 1 ml per minute can be detected. And there's a higher yield, they say, if somebody is hemodynamically unstable. And the advantage of no PrEP, it's not as invasive as a colonoscopy. Still, you'll need to go to angio, but it's not invasive and highly accurate. More than 100% accurate if somebody's actively, almost 100% accurate if somebody's actively bleeding. And you take your standard precautions. If a patient's unstable, they're at higher, and if it's an elderly patient, like most of these patients are, they're high risk of having contrast-induced nephropathy with a blood loss. They might have an acute kidney injury already. Nuclear medicine is another option with red cell scintigraphy, labeled, radioactive labeled red cells. This is used to localize a bleed. It's highly sensitive, more sensitive than the CTA. However, the accuracy of localizing a lesion is a suboptimal to CTA, and it's in question. The bleeding rate for getting the localization of a lesion is 0.1 moles per minute. And also, you need to go to angiogram after you detect your lesion, and this to maximize success of your angio. Advantages of your red cell scintigraphy include that you can inject the radio-labeled red cells and still do subsequent scans after the initial injection. The other important point to note is that most it's actually the best test for like your obscure and overt bleeds. So that, and then in terms of angiography, this is diagnostic and can be used for intervention as well. The rates of bleeding that can be found with angiogram are 0.5 mils per minute. So you can have embolization that can occur, and they use coil, liquid agents, as well as alcohol particles. You can get immediate hemostasis, and 40 to 100% of diverticular bleeds, you get immediate hemostasis. However, there are side effects and there are complications. You can get bowel ischemia, you can get gangrene, that's supposed to say perforation, in 7 to 24% of patients. And in the short term, rebleed is in 10 to 50% of patients. They talk about empiric embolization. If a bleed can't be seen, but it's a massive bleed, and you know and they say in malignancy as well. Surgery can be used, is not recommended as a first line or third line agent at all. So patients should only proceed to emergency laparotomy if every single effort has been made to localize and then endoscopically or radiologically intervene on the bleed. This is last line now. So they talk about emergent total abdominal colectomy or limited resection. So if you do actually localize the bleed, an effort must be made to do that and have a limited resection if required. But an exception to immediate surgery would be an aortoenteric fistula. That you go directly to surgery. Rebleeding rates post-op 18% with limited resection, and 4% with total colectomy. There's a high mortality rate with surgery. These patients aren't great surgical candidates, so it's really not something we want to do, but if it's an emergency situation, there's no choice sometimes. To highlight diverticular bleed, the pathogenesis of the actual bleeds, you have intimal thickening and medial thinning of the vasa recta, and then your vessels exposed. I think next week this is the talk, so I'm not going to go into too much detail, but you have exposure of your vessel. Patients that are at high risk are patients that take NSAIDs. The patients are older patients, and you have abrupt, painless, and self-limited hematochezia. Most 80% stop spontaneously, and rebleeding rate is 53% post-diverticular bleed. And on this data, I think from our textbook, it said emergency surgery in 35% of these patients. This is just an overview of basically what we've already spoken about with regard to diverticular disease itself, but I'm going to skip over that since it's a topic next week. And this is all the interventions that you can use for diverticular disease. First line being through the scope clips. Through the scope clips are first line. And I found this article quite interesting that talked about direct versus indirect clipping of diverticular bleeding. So it says that we've always known that the clipping method for diverticular bleeding is the most appropriate, but direct and indirect, direct being capturing the vessel directly, and indirect being clipping that involves the orifice of your actual diverticular and like zipping, like in a zip-like manner. They wanted to see, because there were no multi-center studies with large sample sizes, to see what was better. And direct clipping, which makes sense, also showed significant reduction in rates of late rebleeding, which is more than 1 year, and your blood transfusion requirements. I just wanted to touch on angioectasia. Angioectasia, colonic angioectasias, occur in the elderly and patients using antithrombotic agents. The first line treatment for a bleeding angioectasia is your APC. That's the first line. It's ease of use, non-contact thermal therapy, safe, and the observations and studies have showed increase in hemoglobin and reduced blood transfusion requirements after. This is another study I looked at the effectiveness and predictors of response to somatostatin analogs. Looking at octreotide, they gave 10 milligrams long-acting release, IMI, every 28 days. And they found these patients had decreased red blood cell transfusion-dependent bleeding, secondary to their gastrointestinal angiodysplasias. Post-polypectomy bleeds, you have you can have delayed post-polypectomy bleeds where you have discrete source of bleeding, locations often known. You use colonoscopy, and heater probe and bipolar diathermy can be used with caution, and then through the scope clips, like your Vesco, plus minus epinephrine. And they say thermal is safer in the thick-walled areas like your rectum, and below your peritoneum reflection. So highlighting drugs when it comes to preventing recurrent lower GI bleeds in patients that are particularly cardiac. Your antiplatelet agents, such as aspirin. Aspirin, basically, you have as primary or secondary prophylaxis. When a patient is on primary prophylaxis with aspirin, we stop that permanently and we do not consider restarting. Secondary prophylaxis is different. You continue the treatment when the patient's bleeding, or if stopped because of a massive GI bleed that's unstable, we restart as soon as hemostasis is achieved. The problem is discontinuation of the aspirin makes the patient 3 times at an increased risk of your cardiovascular complications, your coronary artery disease, and strokes within 7 to 10 days of stopping this. In terms of non-aspirin NSAIDs, we don't use them. We don't recommend them in any of these patients. Some patients on dual antiplatelet therapy, like clopidogrel and aspirin, it's suggested that you continue aspirin and stop whatever other drug like clopidogrel the patient's on. It's suggested that you work in a multidisciplinary team to determine what the way forward is and risk versus benefit with this patient. And it's suggested that we resume after 5 days in the BSG and 7 days, I think it's ACG, sorry, with the multidisciplinary team. Patients that have had an acute coronary syndrome episode in the past 90 days, and those that have had a stent in the past 30 days are at highest risk. Warfarin. So in terms of warfarin, it's suggested to interrupt warfarin at initial presentation. If a patient's unstable, they suggest that you do reverse warfarin. And if they have low thrombotic risk, continue and then restart at 7 days after hemostasis is reached. Your DOACs, stop at presentation. There are reversal agents, which I've highlighted in this next to my text. Dabigatran, patients can actually have hemodialysis for that. And if it's an elective procedure, there's actually a washout period. I think it's 5 days. I need to just double check, but it depends on the drug half-life. We restart at a maximum of 7 days post hemostasis. And in a patient you're particularly worried about rebleed, rather start them on warfarin so we can monitor the levels, etc. This is just a summary of everything that I've said, similar to the diagram I showed previously. And these are my references. Thank you.
Thanks, Barbara, for that like an overview of your lower sort of GI bleeding. There isn't too much I'm actually going to add on. I mean, like most of this is actually there's a approach in terms of an algorithm. So it's very like rhythmic, stable versus unstable, etc., etc. And some of these algorithms can be quite like complex. But I mean, easy to understand, but just lots of sort of lines all over the sort of all over the show. So I think what we tried to do here was just to highlight a few like key areas in these algorithms, and to focus on a few of the etiologies that can be quite like challenging to like manage. Now, on the occasion, and hopefully this only happens rarely, you will have someone refer to you for a lower sort of GI bleed that has probably been in and out of hospital or at the sort of other hospital and has been referred to your hospital or referred to you as a gastro, where the etiology is unclear, and these individuals bleed to the point of requiring transfusion. They needed to be resuscitated. And of course, the bleed can be anywhere in the from the upper from the stomach, upper GI tract, small bowel, and of course colon. So I think they can be quite like a challenge, and we really haven't spoken too much about small small intestine. Small intestinal bleeding, there is an approach over there as like well, and I think plenty of it will center around you able to do a if you're able to do a video like in a capsule endoscopic examination. The only extra things I would add is this issue of red cell scintigraphy and even a angiogram. You can sort of see the red cell scintigraphy sort of going hand in hand with the angiogram. Of course, the angiogram is a bit more specific, and it allows the interventional radiologist to also do like a treatment. The main issue then is you need a patient who is actively hemorrhaging at the time. And as was highlighted by sort of Barbara, most of these like patients, when they are referred to you, they've already had their like bleed and it's now stopped. Very rarely, as I said, these are patients sometimes who have been in and out of hospital. If you really, if you and your interventional radiologists are fairly enthusiastic and brave, you can try and do a provocative angiogram. I think at our unit, we've had to ask for a provocative angiogram in the few years that I've been there about 3 times. And the yield from that has, I think we only were able to find the source of the bleeding in a single individual. So what do I mean by provocative angiogram is you actually hand them, as the angiogram is being performed, you heparinize and you try and provoke a GI GI or hemorrhage. Okay, so and the only other thing that I may want to ask Barbara is, in your sort of reading, was there any role for an urgent CT scan or a CT angiogram?
So in terms of a role for urgent CT angiogram, in a very unstable patient with a massive bleed, it was suggested to do the urgent CT angiogram in preparation for a possible embolization in an angiogram suite via catheter angio.
Okay. Okay. I think if there's anyone in the audience, I'm just going to go through the chat here. And I see there's a question from Zambo. Can you see that?
Oh, let me open it.
Barbara? Thanks, Barbara. What role of OGD in workup of patients with acute LGIB? So I suppose you mean what role of a upper scope in the workup of patients with acute lower GIB? I think you have highlighted it, but I think let's just emphasize it.
Okay, so the role of gastroscopy in a patient that presents with hematochezia, a patient may be having a massive upper GI bleed with an upper GI cause. So they can still have a brisk bleed with bright red blood with an upper GI bleed and tend to be more unstable than your lower GI bleed. So it is important to do a gastroscopy in patients like that to exclude an upper GI bleed. And in one of the guidelines, it did say make before a CTA, if the patient is going to tolerate a gastroscopy, rather do a gastroscopy before doing the CT angiogram.
Yeah, I think I would actually fully agree with that. I think you should have a low threshold to do a upper scope. Look, I mean, it's fairly obvious. If you got somebody who's shocked, who's having your red PR bleeding, and these people, you can spot them. They aren't well. These people, they're not well at all. I think there you'd really want to have that upper scope performed out of the as early as you can. Because to actually be honest, all sorts of upper GI hemorrhaging are easier to resolve or sort out endoscopically than trying to hunt for something in a in the sort of large bowel, where the other issue is preparation. So often when you enter these patients, and yes, we heard about speaking about giving your rapid prep about 4 liters. But that isn't easy to do in somebody who's having active bleeding and presents in the evening, and you say, okay, I'm going to do an urgent scope early in the morning. So to have these patients adequately prepared for a colonoscopy can be, I really haven't found it so easy. And often when you do scope them, you still find a fair amount of effluent, and it's altered altered blood. So I'm just seeing if there's anything else on the chat. Asheko says, do not forget the emerging role of video capsule endoscopy for small intestinal bleeding. Superior to angiogram must be done early and when there's no obstruction. Yes, Asheko, I think certainly for small intestinal bleeding, we agree. The focus here, I think, was primarily on large colon, but as we said up front, theoretically, when we do speak of lower GI bleeding, it's bleeding from beyond the ligament of sort of trites, which will include your small bowel. Are there other questions or comments? Also, these scoring systems, I mean, Oakland scoring, breeding system. Yes, I think they're there. They're helpful to make some kind of evaluation up front and evidence. But, you know, if you have someone who's got a systolic pressure of 70 and a heart rate of 84, you know, and I mean, it's fairly obvious. I'm not going to send anyone home with a you know, SBP of which is low, who just came in with a upper GI bleed. So yes, there is this decision about if you can send someone home and ask them to, you know, return. But I think in most of the situations, you don't really need a scoring system to say, yeah, he's going to be hospitalized and he needs an early scope. Chioma Francisca, like Barbara, any role for barium enema?
There's no role for barium enema in an acute lower GI bleed for a patient that is unstable. I think none of the guidelines actually mention barium enema for an acute GI bleed, not at all.
Yeah, no, I also haven't really seen anything about a enema being used. I mean, the only enema you should be using is if you want to sort of clean up the sigmoid for visualization for a scope. I don't think it's going, if you do a barium enema, it's going to seal the hemorrhage, and also after you do the enema, a barium enema, it's fairly hard to do a adequate colonoscopy because the mucosa will be covered with like a barium, so it makes visualization a bit of a problem. Mashiko, is there anything you feel like adding?
No, Dr. Naidu, that was excellent. Thank you.
Thank you. Ramonate, like Noni?
Yeah, hi, Vijay. Hi, everyone. No, thanks. I'm happy. I'm fine. That was excellent.
Thanks.
Actually, Barbara, I said so on the comment.
Thank you.
Yeah. Thank you, guys.
Thanks. Yeah, how do you all feel about these scoring systems? I mean, when we were reading over it, and I was like staring at some of these scoring systems about should the lower GI bleed be hospitalized? Should it be sent home? Yeah. I think it mainly alludes to the fact that, look, one of the most frequent things that will cause a lower GI bleed, strictly speaking, in the community are hemorrhoids, isn't it? And hemorrhoids will rarely present with the unstable EVS.
Can I comment, Vijay? I'm not sure.
Yes, yes. Please feel free.
Thanks, Vijay, and thank you again. This scoring system was starting with that Oakland score. I think it helps in terms of triaging, especially when you are in a so-called resource limited settings, you see, because at least you can decide, should I keep these guys in the casualty for tonight, or should we expedite maybe surgical intervention, like further evaluation, basically. So I would imagine if somebody has got that, what do you call that score, not the shock index. Yeah, the shock index, yes, shock index. If it's low, basically, mean the patient needs to be seen. If it's more than one, it's more than one. Right. So, I am repeating myself. I think in terms of triaging, especially when you want to decide who has to be observed or overnight just in casualty, or who might have to go straight for admission to surgery, such things. I think it's just a guideline. Obviously, it's a guideline. It's not hitting. It's not a guideline just to guide, like at least.
Yeah. No, I actually completely agree. The unfortunate thing is, I mean, there's so many scoring systems. Obviously, we all have smartphones and apps. So I think if you are confronted with a lower, if somebody gives you a phone call about somebody who presents to like a casualty about a lower sort of GI bleed, hopefully you have your, you can ask them, please return the phone call. Let me have a look at my sort of app on my smartphone and do a scoring system, and then, you know, give some kind of what sounds like a reasonably educated answer with evidence, of course. But to, you know, but as I said, I mean, usually you're going to see immediately if someone needs to be hospitalized or, you know, not. I mean, you know, they're shocked, it's etc. That'll be fairly obvious.
Yeah. And then, oh, sorry. Another thing is, from what I read, actually, is just that this Auckland thing and your shock index, this ones that has been presented, is the BSG feels strongly about it because they think it's the one which has been mostly validated, I think, more than any other scores. I mean, there are many, of course, but this one, it looks like they really believe in it. So I think it works better.
Okay, so I think if they aren't, okay, I think there's one from Peterson. Where should the endoscopy take place in terms of bleeds? Theater or your ICU? Wherever the scope is, I suppose, is an easy answer, but I'll leave that to...
That's why the scoring system comes to play, you see. Anyway.
Barbara.
Yes.
Where should, if somebody has, I'm assuming
Unstable.
Dale is referring to a lower sort of GI bleed, and is asking where should the scope take place.
So the patients that we said for colonoscopy are actually the stable patients, and then we said major bleeds with the Auckland. So the patient should be be stable according to our scoring system. So it should be okay to take the patient to a normal endoscopy suite, even if it's a major bleed, if I'm thinking logically about it. Because your unstable patient will get the CT angio and go to interventional radiology. So, but I'm not sure. I didn't see anything.
I have no easy answer for you, but I think it will depend on your circumstances and how stable this patient is. So if you have someone who's just got an ongoing hemorrhage and a bleed, and it already looks upfront, and you really haven't got easy access to an interventional radiologist within a few hours. It just depends on your circumstances, and again you have involved your surgeon early. Then you may just ask your surgeon to say, look, how about, this guy is really unstable, this patient's really unstable, how about we try and scope him in the operating room, and if we aren't able to find the bleeding or control the bleeding, you may need to just then immediately go and do an urgent colectomy. So I think it depends on your circumstances, and I think we have been in that situation rarely, and our surgeons are happy to scope the unstable individual on the operating like a table. When I say unstable, it basically means someone who's having ongoing hemorrhaging, bleeding, and you really aren't able to shift them. ICU, I would say no. I think if this patient's already in the sort of ICU and they have a bleed in the ICU, I think over there it's fine. But if the patient has presented with a lower sort of GI hemorrhage bleed, and they are so unstable that they were housed in the high care or like ICU, and if you're going to do a scope on that patient if you're able to. And if you have a surgeon who's fairly, ideally scope them in the operating room. Ain't sure if anybody has any other view. Again, it depends on your circumstances. So everyone, it's almost 7, so it only leaves me to end. I'd like to thank the presenter and ECHO, University of New Mexico, and the ECHO India sort of a team for their support. Feedback form is available in the chat over there. Please fill it in. And also we'd like to say thank you to the foundation. The next presentation will be on the 19th of September, and that topic will be on diverticular disease, including SCAD. I think for some of the fellows, you can go and you read up on that acronym, SCAD. And the presenter will be Dr. Innocent Francis from Curtis Heath Hospital, and the chair for that meeting will be Ernst Fredericks. Okay, everybody. Appreciate it, and enjoy the remainder of your evening and the rest of the sort of week until we see you again.